Well, we're going to go ahead and get started. Welcome to the internal medicine grand rounds, and we're following a cycle where we're having different of the specialties give a sort of an update of internal medicine and particularly infectious disease this month. We have three very excellent speakers today, Dr. Susan Hoover, and then Dr. Shu, and then Dr. Wendell Hoffman. All are from Sanford Infectious Disease, and I'll go ahead and let them go ahead and start off. I think Dr. Hoover is going to start off today. So.
Thanks. So my topic today is going to be pneumonia. So update on community-acquired pneumonia. Just a couple of points of things that have come out more recently that I think might change some of our practice. So according to the HCUP database, the most frequent conditions for which people are discharged from U.S. hospitals, this is in 2011. I wouldn't have guessed the first one, it's being a newborn baby. But the second one is pneumonia, followed by other familiar internal medicine diagnoses, septicemia, congestive heart failure, and osteoarthritis. So this is still a very significant number of our inpatient admissions. And this talk kind of focuses on inpatient community-acquired pneumonia.
Updates on infectious disease.
So I'm going to talk about a little bit about the etiology of community-acquired pneumonia, and then on some new papers that have come out about how long we might need to treat community-acquired. So this is a fairly recent study trying to track down what organisms are responsible for pneumonia. So this is sponsored by the CDC. It's called the EPIC study, Etiology of Pneumonia in Communities. And it took place fairly recently, 2010 to 2012. And they were looking at, for adults, 5 hospitals in Chicago and Nashville. Salt Lake City is on the map because that was a children's hospital they were looking at in the We're talking about adults today. So they looked at all inpatients with community-acquired pneumonia. They excluded people who had been admitted in the past month, people who had been, came from a nursing home, people with tracheostomies, ventilators, cystic fibrosis, other things that would make the pneumonia less straightforward. And they did extensive diagnostic studies. They tried to get all consecutive patients, and they got about 2,400 out of 3,600 that were eligible. And they did extensive studies, blood, serum, and urine, not only for culture, but for for molecular detection tests and antigen tests. And after a while, they added some controls. They were people from only Vanderbilt in Tennessee presenting to an internal medicine clinic for other non-pneumonia related problems to try to see how common some of these pathogens are in the healthy or the non-pneumonia population. So they did all this diagnostic testing upon admission, and this is what they found. So as with many studies of the etiology of pneumonia, the most common pathogen isolated was no pathogen isolated, and that was, I think, 62%. If you break it down, about a quarter of them, this light blue wedge here, had a viral infection, either with or without bacteria. 14% altogether had bacterial infection. That was either alone or with another pathogen, usually a virus. And then these bars here are the individual pathogens. So most common is human rhinovirus, and then influenza, and then Streptococcus pneumoniae. These are the percentages. So the very highest percent is only 9% of cases, and that was for human rhinovirus. And these are the individual numbers, so they're measured in the tens to hundreds. And then the seasonality, this shows over several years, like 3 years of the study. Influenza is the red line, so it occurs in the winter. And human rhinovirus occurs in the fall and spring, as we would expect. So the most common pathogens altogether were all age groups of adults. This is only the people over 18. Human rhinovirus in 9%, influenza virus in 6%, and Streptococcus pneumoniae in 5%. If you look at the people who were in the ICU, the more common pathogen in the ICU was Streptococcus pneumoniae was still number 1. Staphylococcus aureus was 5% of ICU patients versus 1% of non-ICU. And Enterobacteriaceae were detected more in ICU patients, but all of those were still, a minority of the patients that they studied. We talk a lot about the necessity of collecting your specimens before you start antibiotics. So what if they collected the specimens after antibiotics? In the case of blood cultures, it made somewhat of a difference. So only 78% of the blood cultures were collected before antibiotics. and 7% were positive before versus 3% after, and the numbers were high enough that that does have a suggestion of statistical significance. Among these antigens, so these are non-culture antigen tests in the urine, very, very small percentage of them were positive, and it didn't seem to be affected by prior antibiotic treatment, but it's probably that the numbers are so small it's hard to show a difference. Sputum culture is more likely to be positive than blood, 23% versus 7% with pretreatment, or 11% versus 3%, did not reach statistical significance. But your yield, I take home from this that you want to try to do antibiotics before blood cultures if possible. The yield from sputum is going to be better than blood, which we kind of know that. The challenge is getting sputum. The patient either isn't coughing it up or the cup is across the room and the trash can is a lot more convenient. These PCR tests on pleural fluid or NP or OP swab were not very often positive and didn't seem to be affected by antibiotics. So even when it looks like there's a big difference in the numbers, the total numbers is so tiny that your p-value is not very impressive. What about controls? So these human rhinoviruses are detected in quite a lot of cases, 11%. They started wondering how many healthy people who don't have pneumonia have these pathogens. And at least in this study, it was uncommon. I didn't do it. Did I? Can we get audio-visual help? We're not seeing our slides anymore. It was uncommon for the controls, the healthy people, to have human rhinovirus or to have any pathogen. So it was only 2% with any pathogen, 1% with human rhinovirus. So the take-home points of this EPIC study were, when a pathogen is detected, it's most often a virus. If it's a bacterium, it's most likely Streptococcus pneumoniae, whether or not your patient is in the ICU.
I think it worked. I can hear her.
I think we need to mute some of our remote site.
Will it just take a second?
Okay. And Streptococcus pneumoniae, this is actually nothing new. In 2010 to 2012, it's the same information as in older studies, that pneumococcus is the most common identified cause of bacterial pneumonia. Any age, ICU patient or ward patient. And how long should we treat community-acquired pneumonia? This is kind of the second point I wanted to make. So I have a lot of text I can read you here. Here we go. So many ID people will make a joke that in the Roman Empire they decided that there would be 7 days in a week. And that's why we think in terms of multiples of 7 when we talk about duration of antibiotics. In early case series of pneumococcal pneumonia, so in 1943, not that long after the discovery of penicillin, there was a report on, thank you, Dr. Ziegler, of 500 cases of pneumococcal pneumonia treated with penicillin. And this really was saving people's lives with pneumococcal pneumonia at the time. There were high cure rates with only 1.5 to 4 days of therapy. A later study by Meads in Finland noted a similar high survival rate, pneumococcal pneumonia, penicillin, if they treated only until 2 or 3 days after the fever resolved. I think the text might not be clear. They treated them until 2 or 3 days after they weren't febrile anymore. Survival rate was good. They noticed 2 what they called relapses, of which one was infected with a different serotype this time. So one of them was pretty clearly a reinfection, not truly a relapse. Somehow, that has gotten translated in our modern times into longer treatment is better, and that prolonged treatment will prevent drug resistance. I think we've all heard that maybe growing up as a layperson. If you don't finish all your antibiotics, resistant organisms will develop. Believe it or not, there's not much scientific basis for that. It's something that kind of got ingrained in our minds over time from studies like this. And I noted, and so there are some studies showing that longer courses actually lead to more resistance. This is all from the ICU. But looking at studies of antibiotic therapy for ventilator-associated pneumonia, the first one is from JAMA 2003, and they found that people who got 8 days versus 15 days of antibiotics for ventilator pneumonia were less likely to have resistant pathogens. The second one was similar. Patients with pulmonary infiltrates in the ICU receiving an experimental shorter course of antibiotics were less likely to get antibiotic resistance or super infections compared to the people getting standard therapy, which at the time was probably at least 10 days, maybe more like 14 days. So these are sort of observational, non-randomized studies, but it led to the thought that maybe longer courses are not necessary. And I noticed on the CDC's Get Smart website, which is their sort of promotion of responsible use of antibiotics, it used to say, in advice to the patient, finish the prescription even if you feel better. So I found that in an article, so I went looking for it, and now it says, take the prescribed antibiotic exactly as your healthcare professional tells you. So the CDC, I don't know if they consciously changed the language, but it's interesting that they don't want to come down on the side of saying you must take the longer course. So these are the Infectious Disease Society of America, American Thoracic Society guidelines that many of us are familiar with. And their current guidelines, which are from 2007 already, say you should treat for a minimum of 5 days until afebrile 48 to 72 hours, and there is no more than one sign of clinical instability. And they comment that the 5 days is supported by a trial using levofloxacin for pneumonia, in which 5 days was equivalent to 7 to 10 days. The signs of clinical instability we've seen a lot, basically a high temperature, fast heart rate, fast respiratory rate, low blood pressure, low oxygen saturation. It's commented that there's really not good clinical trial evidence. These are all sort of things that make sense in terms of what we would expect in a patient who's clinically unstable. And the guidelines recommend 7 to 21 days if the etiology is methicillin-resistant Staphylococcus aureus, with, as far as I can tell, no evidence behind that at all. Probably more, no clinical trial evidence, probably more clinical experience. So they don't really discuss in the guidelines why the difference could be all the way from 5 days to 21 days with that particular pathogen. This is kind of an older article, 10 years old now, with a suggestion that shorter courses for community-acquired pneumonia might be just as effective. This study was in the Netherlands in the early 2000s. They included adults who were hospitalized with mild to moderate community-acquired pneumonia. Again, they excluded ICU. They excluded patients who had been in the hospital or had antibiotics. And they excluded people with a suspicion of staphylococcal pneumonia. So they gave them all IV amoxicillin, which was the standard of care in the Netherlands at the time. And after 3 days, they had a score by which they rated them. Are they improved or are they not improved? If they're not improved, they continue them on treatment. If they're improved, at that point, they randomized them to 5 more days of either amoxicillin or a placebo. So the people in the amoxicillin group, of course, got 8 total days of therapy, and the people in the placebo group got 3, and the cure rate was the same in both of them. It was not a huge study, 186 patients, but it led to some idea that this could be studied further. So this study came out just last year, also in Europe, in teaching hospitals in Spain, in which they used a similar strategy. So they had people with community-acquired pneumonia, usual exclusion criteria, no ICU, no nursing home, no recent hospital admission. And they randomized them. Again, they treated them, in this case, they didn't choose the antibiotic. They just said, treat with whatever is clinically appropriate. And on day 5, you randomize them to either stop the antibiotic, again, if they don't have these exact same signs of clinical instability, continue the antibiotic with the choice and duration determined by the treating physician. And they were looking for clinical success at both 10 days and 30 days, and then they used a validated community-acquired pneumonia symptom score, which has been used in other studies to determine how high their score was at 10 days. They again, define clinical success as resolution or improvement in signs and symptoms related to pneumonia without further antibiotics. And to note, this study is done in Spain, so 80% of the patients received quinolones, which is probably somewhat higher than we would have in the United States, and they exclude patients with MRSA. So, both the intention to treat and the per protocol population are similar. In terms of clinical success at day 10, 48% versus 54%, no statistical difference. And at day 30, 88% versus 91%, again, not significantly different between 5 days of therapy and however many days of therapy were determined by the treating physician. And then the symptom score, the scores went down similarly in both groups as time went on. So from 24 to 18, from 27 to 18 at 10 days versus 30 days. And between the two types of analysis, it showed kind of the same thing. The time receiving antibiotics median for the intervention group was 5 days because they'd been randomized to stop, and then the median was 10 days for the people who were continuing according to the physician's discretion. And looking at readmission, actually there were not very many readmissions at all. Actually more in the longer duration group, but not enough to really say that there was a statistical difference. So the take-home points from this study was withdrawing the antibiotic based on clinical stability at 5 days was not inferior to continuing the antibiotic in the traditional duration or at the treating physician's judgment. And then, therefore, the guidelines that are published concerning antibiotic treatment recommending 5 days essentially could be safely implemented among hospitalized patients with pneumonia, with the caveats: no Staph aureus, no ventilator, no previous admission, and again, the caveat: this is occurring in Europe, and there's a lot of quinolones being used for these patients. So from my portion of the talk today, I think the updates are: etiology of community-acquired pneumonia in 2017 has really not changed. Respiratory viruses and Streptococcus pneumoniae. As for how long we need to treat, I think this is evolving. We don't have all the answers yet, but the 5-day course as recommended in the guidelines does have support, again, for non-ICU, non-Staph aureus pneumonia. Thank you.
We're going to switch gears a little bit and talk about beta-lactam allergies and antibiotic stewardship. You'll notice there's a little bit of a thread among all three topics, kind of talk about stewardship, duration of antibiotics, talking about allergies, and then C. diff. So that was kind of our theme. So just start off with a quick case. This was a recent case that came across the ASP, the Antibiotic Stewardship Program. 30-year-old woman with ovarian cancer is hospitalized with neutropenic fever. She reports a history of rash after receiving penicillin as a child. Due to prior outpatient courses of levofloxacin and relating concern for the fluoroquinolone resistant, she was started on aztreonam and gentamicin upon admission to the hospital. So we'll just let that linger for a little bit. Is that the best regimen for this patient? What could you do to maybe tune up her antibiotics a little bit more? And we'll come back to it at the end. So beta-lactam allergies is a common problem. We all see this in our practice on a very regular basis. Drug allergies are reported overall. When you look at all drug allergies, about 20 to 40% of patients in the U.S. report some type of drug allergy. Unfortunately, that gets intolerances lumped into that category. Of these, beta-lactam allergies are clearly the most common. They're reported by about 8 to 25% of patients, reporting across a spectrum of settings, ambulatory and inpatient settings. And then a very small chunk of patients additionally report a cephalosporin allergy, about 2% on top of reporting a penicillin allergy. It's been estimated in several studies that about 90 to 95% of these are not true allergies for a whole variety of reasons. Probably intolerances being the most. Somebody had upset stomach, had diarrhea, they didn't feel good on an antibiotic, and it gets lumped together into the allergy section of their chart. Or their known side effects of the drug. You oftentimes will see a patient who has an erythromycin allergy listed in their chart, and their complaint is diarrhea associated with it. So some of these are expected side effects. They may be misclassified by a medical provider. This young child who had a viral exanthem, as we know rashes are common in kids, it's very easy to get labeled as a penicillin allergy early in life. And then one other caveat, which I'm not really going to focus on this today, but if you talk to immunologists and allergists that specialize in drug allergies, a previous reaction, even a true IgE-mediated reaction, can wane over time, and so a previous reaction does not necessarily imply that they will have a future reaction to that same drug. Particularly with aging, those responses can wane. So when we think about beta-lactam allergies, it obviously covers a huge spectrum of drugs. It is typically sensitization to the side chains. So you have the beta-lactam ring, the thing that's in common amongst this whole class of antibiotics. That is a less common etiology of an IgE-mediated reaction. More often they're related to the side rings or the side chains, both for the immediate and the delayed allergic reactions. So if you take somebody who has a true IgE-mediated allergy to penicillin, less than 5% will have in vivo cross-reactivity to a first or second generation cephalosporin, and less than 2% will cross-react with a second, third, or fourth generation cephalosporins. So this is really kind of a key thing to take into account when you're considering the risks and benefits for prescribing a particular antibiotic regimen. Older reports showed higher rates of cross-reactivity between the agents, and that's likely because there was significant contamination with penicillin amongst other cephalosporins. So cephalosporins were contaminated in the manufacturing process with penicillin derivatives. The thing that's interesting and supports this, if you look at series of penicillin skin tests over the last 2 decades, there's been a very steady decline in the rate of penicillin skin test positivity. And that's really because the manufacturing processes have improved so much. And so I point this out specifically because if you've got your 80-year-old patient in front of you that's telling you they had a childhood reaction to penicillin, it's worth delving into that a little bit more, because the likelihood that they would still cross-react to a penicillin, particularly if they had a mild reaction, is quite low. So let's talk about what are the harms of a beta-lactam allergy. Why do we care about labeling our patients with an allergy? So this was actually, this study was listed as a practice-changing article for 2016 in several sources because it really focused in a larger series about what are the outcomes of labeling people with a penicillin allergy. So it was actually done by residents rotating on the infectious disease consult service at 3 hospitals in Toronto. It was initiated as a quality improvement project in this health system, and then they obviously turned it into a bigger publication for clinical infectious diseases. They prospectively assessed patients' allergies as they were seeing them on the consult service, and then they retrospectively collected data about the outcomes of their hospitalization. So particularly focusing on the primary composite outcome of hospital readmission, C. difficile infection, drug reaction, or acute kidney injury. And to achieve power they needed with this group of patients, those were lumped together as one composite outcome. And then they did look at them all separately. So they collected data on 507 patients who received antibiotics. 19% of those, or 95 patients, reported a beta-lactam allergy, which is in keeping with most of the literature. Among those patients that reported a beta-lactam allergy, they assessed that 72 or 76% would be preferred to receive a beta-lactam. So and this is based on concordance with published guidelines and what the specific site of infection is, the bug-drug combo, all of those factors. So this was really what they assessed on a prospective basis as they were seeing these consults, deciding what the optimal antibiotic would be. Amongst those patients where a beta-lactam was the preferred option, 47 patients, or 65%, received the beta-lactam, 25 or 35% received the alternative. And what they found, kind of just a very high-level look at their outcomes, 40% of the patients in the alternative therapy group met the primary outcome. Either they were readmitted within 30 days, they had C. diff infection in 3 months, they had an adverse drug event, or they developed acute kidney injury. Whereas in the group that had received the beta-lactams in spite of their reported allergy, only 21% met that primary outcome. And this 40% was primarily driven by readmissions and drug reactions. So the irony of this is even though providers knew a beta-lactam was preferred, they received an alternative, this group still had a statistically significant higher rate of adverse drug events. Now, there's some confounding issues there because obviously you have multiple drug allergy syndromes where people are going to be predisposed to additional drug reactions. But the take-home point was that we're not doing these patients any favors by giving them alternative therapy. So in this study, they obtained an allergy history from all the patients prospectively. Despite this, as I said, 35% of the beta-lactam allergic patients were not given a beta-lactam when indicated. When they compared that to what prior studies have shown, 22 out of 24 of those patients would be estimated to tolerate a beta-lactam without any troubles. And so they make the point that this subpopulation should be investigated further, either with the help of an allergist or investigating their allergy history, because upon more thorough evaluation, a large majority of those probably would have done fine with a beta-lactam and had the potential for a better outcome. So I picked one representative study to look at this. There have been several studies that show that patients labeled with a penicillin allergy have increased rates of C. difficile infection and colonization and infection with MRSA or VRE. So this was a large retrospective look. This was from the Kaiser Permanente Hospital System. They looked at an administrative database that had over 51,000 patients that they looked at labeled with penicillin allergy. Now this was all comers, anybody who had penicillin allergy listed in their chart. They matched those to 2 non-allergic controls based on sex, diagnosis category, age, and date of admission. And they found that the case patients, the penicillin allergic patients, had 23% more C. diff infection, 14% more MRSA infection, and 30% more VRE infection. So, and the other take-home point, and this is kind of what I'm going to expand upon right now, when they looked at those case patients in more detail, they received significantly more fluoroquinolones, clindamycin, and vancomycin compared to the non-allergic controls. So this kind of points out a huge opportunity for antibiotic stewardship. I think in large part when we talk about stewardship, we're looking at the macro level, we're looking at implementing hospital programs to implement antibiotic cycling, prescription restrictions, focusing on appropriate durations of antibiotics. And so I picked out this one thing to look at the micro level today because this hasn't traditionally been included in stewardship programs, but I think this is an upcoming push that we'll see more of, is to really include allergy delabeling as its own category in stewardship interventions. So there was a study completed in Australia. It's the National Antibiotic Prescribing Survey. It's done annually. It's just a point prevalence audit of inpatient antibiotic prescribing over the whole country. 21,000 patients received antibiotics in the time period that they looked at, 2013 to 2014. Allergy label was recorded in 18%, again, kind of in keeping with around the 20% mark. And what they found in these patients is that, as expected, they had lower beta-lactam use, much higher quinolone, glycopeptide, and carbapenem use. And they found in the subset of patients which were immunocompromised, and this was a lumping of HIV, solid organ transplant, and malignancy on chemotherapy, they found that those patients were particularly at increased risk for inappropriate antibiotic use, with very high rates of fluoroquinolone and glycopeptide use. And so if they compared the two groups, so AAL is the antibiotic allergy label versus the non-antibiotic allergy label, you can see here, as expected, the non-allergic patients in the penicillin category had a higher rate of penicillin use compared to those labeled in the allergies. All of those differences were statistically significant across the board. So the dark bars you can see there had higher rates of tetracyclines, sulfa, macrolides, glycopeptides, fluoroquinolones, as you would expect, all the alternatives to beta-lactam. Keeping in mind that in many infections, beta-lactams truly are our first line for therapy. So when they looked specifically at the appropriateness of prescribing, this was defined as guideline concordance when reviewed by a panel of experts. So it was really, were they using first-line therapy? In the patients labeled with a beta-lactam allergy, 33% received inappropriate prescriptions, whereas 30% received them in the non-beta-lactam allergic group. Similar numbers for penicillin, and then glycopeptides, you can see, was the reverse, because the beta-lactam patients tended to get more glycopeptides. So opportunities here to improve our prescribing practices. So some of the areas that are really under development from a stewardship standpoint, and some of this was taken, I apologize, that table is small. This was a survey of infectious disease physicians through the Emerging Infections Network that was published just late last year. And essentially it was surveying ID providers in the US to figure out what are your availability for allergy testing services, how regularly do you avail yourself of those services. And so what they found was about 57% of the providers that responded had the availability of desensitization, 43% had availability of a traditional skin testing, which we'll come back to, and 40% with oral challenge. But you can see about a quarter didn't have access to any of those services. So again, something that we could develop as part of our stewardship interventions, integrating this into our antibiotic stewardship program so that we can potentially delabel people who have historically had a penicillin allergy label. And so with the ASP push, we want to increase our beta-lactam use, obviously appropriately, duration and drug choice, and potentially this reduces the antimicrobial cost, as beta-lactams as a whole tend to be less expensive than our other classes of antibiotics. And so people have really started looking at this being a pharmacy-initiated process to do the penicillin skin testing. So that's kind of the theoretical, that's kind of where things are going. But when you think about what are our options for what can I do now? If I have a penicillin allergic patient in front of me, what are my options? So I think this is a nice algorithm. So there's essentially a two-step approach that, you know, an average internist or any subspecialist can use. And that's first is historical delabeling. So really just asking them, well, what was your allergy? As soon as they tell you they're penicillin allergic, delve into that a little bit more. Well, how old were you? What happened? What was your illness at the time? I mean, if it was the high school kid who was diagnosed with mono but got amoxicillin just in case, probably you could delabel them based on that information alone. Additionally, you want to know what the severity of their reaction was. Obviously, if they describe a clear IgE-mediated anaphylaxis, that's going to send you down a different path versus, I got a weird rash a few days later, but I also had new medications at the same time. So if they have a history of another type of reaction, your option would be, so if it's a mild reaction, it's unclear that it was penicillin driven, would be just to go ahead and challenge them with a penicillin cephalosporin or carbapenem, using potentially a test dose protocol, giving them 1/10 the dose and escalating under close supervision. If they describe a history of an urticarial rash, pruritus, angioedema, bronchospasm, things that are suggestive of a true IgE-mediated allergy, then your next step is to move toward intradermal testing before you give a penicillin or carbapenem. And we'll talk about that in just a minute. And then from there, if the skin test is negative, that has about a 97 to 99% negative predictive value. So if you get a negative skin test, you are reasonably safe to go ahead and challenge with penicillin, cephalosporin, or carbapenem, probably doing that in a supervised situation where you have access to emergency care. If they have a positive skin test, then obviously that kind of confirms things for you. You really are going to try to avoid the B-Lactam class or involve an allergist potentially for help with desensitization regimens, depending on what you're needing to treat. Right, so just a sample of what the penicillin skin testing looks like. So they get an intradermal injection of penicillin G, they get an intradermal injection of PrePen, and then saline for the negative control and histamine for the positive control. And then these are monitored for 15 minutes to look for that wheal and flare reaction that would be typical of an IgE or mediated response or a type 1 hypersensitivity. So again, just to be really clear about this, we're looking at IgE-mediated allergies with this intradermal testing. We are not evaluating anyway people who had a type 4 hypersensitivity, some type of delayed reaction, DRESS syndrome, Stevens-Johnson, those kinds of things. That's obviously going to be, we're going to have to approach that differently. So this is looking just for true IgE-mediated allergies. So Nick Skibba, who's one of the Sanford pharmacists, kindly shared this data with me because as a resident, he implemented an inpatient penicillin skin testing program at Sanford, and he's carrying these data forward now to actually look at the effect on antibiotic prescribing. So this was implemented in December of 2013. It's a physician-initiated order. A pharmacist performs the test after a review of the exclusion criteria. There is quite a list of exclusion criteria. The pharmacist comes behind the physician and reassesses the allergy history. What medications do they know they've tolerated? Have they tolerated a similar beta-lactam that you could avoid the testing? You have to be off any medication that can impact your histamine production, so that would be even things like H2 blockers, which lots of our patients are on. So there's a variety of exclusion criteria that they go through. 238 skin tests were completed as of March 18th. 208 were negative, 24 were positive, and 6 were indeterminate. So that potentially means they reacted to one of the control. Either they reacted to the negative control or they did not react appropriately to the histamine. So that's a rate, if you just look at the positive and negatives and you kind of throw out the 6 indeterminates, that's a rate of about 10% positive, which is in line with published literature. So as I said, the analysis of this program's effect on antibiotic prescribing is underway. So if we come back to the 30-year-old woman with ovarian cancer who's hospitalized with a neutropenic fever, as we said, she'd had levofloxacin as an outpatient, so there was concern for resistance, but she reports a penicillin allergy as a child. Is this the best regimen? And we argued no from the antibiotic stewardship standpoint. We said, you know, for one, you've got a spectrum of activity issue. You're kind of missing the gram-positives here, which are key in neutropenic fever. But more importantly, this woman, when you looked back in her chart, she'd had a lot of medical care in relation to her ovarian cancer, and she had had every antibiotic class I can name outside of beta-lactams. But when she was then later pressed, it turned out that this was a mild reaction. It happened in childhood. She had never been re-challenged with a beta-lactam after that, but she had tolerated cephalosporins. So this would definitely be someone that you could either choose to challenge with a beta-lactam under supervised setting, or depending on the provider preferences and patient preference, would definitely be appropriate for intradermal skin testing to hopefully reduce her her non-beta-lactam use over time. Thank you.
Thank you very much. My name is Wendell Hoffman, and one of the ID group here at Sanford, and those are outstanding talks by my colleagues. I'll try to be a faint memory of this session with what we do with a very challenging subject, which is what is the optimal approach for the detection of Clostridium difficile infection. You would think that this organism would just go away in terms of our consensus and what we agree upon and how we make the diagnosis and how we treat, and it continues to plague us. Nucleic acid amplification tests are also called NATs. You'll see different terms, NADs, nucleic acid detection, or PCRs, essentially all equivalent, have become the predominant method for use for C. difficile infection in the United States. This all came about practically back around 2011, although the tests had been under development for several years before then. And the reason while everybody jumped on the bandwagon, it was because the historical test, which was an immunoassay looking for the toxin produced by the organism, not the organism itself, which looked for both A and B toxins, had been used, but was considered very insensitive, on the order of 65 to 70%. Some studies would put it higher than that. But there was a definite need for us to be able to say whether or not the organism was present. And so these nucleic acid amplification tests came about and were implemented, including our organization, which back in 2011 moved towards PCR testing as a part of a company we actually used as a Cepheid platform, where it was a plug and read, very sophisticated, very easy to use platform. And so as predicted, our C. difficile numbers rose significantly. And fast forward now, then we have entered a new era of debate, and that is, what does a positive NAT even mean? How should it influence my antibiotic prescribing? What does it mean for infection prevention and control? And so forth and so on. So as we began and entered the era of nucleic acid detection, the CD rates increasingly became on the radar of federal regulatory programs, and specifically hospital-acquired reimbursement programs. And so they've become now an important metric impacting hospital safety ratings and value-based purchasing, and with millions of dollars of reimbursement at risk. So with that as part of the background, we have this then as an additional part of the background, and that is that the infectious disease community was, I think, significantly, me included, impacted by this, as well as a number of other papers, some coming out of Europe, that began to focus on the overdiagnosis of C. difficile in the molecular era. And their conclusions, which I've blown up here on the right-hand side, was to highlight the importance of measuring not just using the NAAT, the PCR, but also utilizing the toxin as a way in which you could perhaps determine whether or not the patient had what we call CDI, or C. difficile infection, versus C. diff colonization, right? So their conclusions were that among hospitalized adults with suspected CDI, virtually all CDI-related complications and deaths occurred in patients with positive toxin immunoassay test results. Patients with a positive molecular test result and a negative toxin immunoassay test had outcomes that were compatible to patients without C. difficile by either method. Exclusive reliance on molecular tests for CDI diagnosis without tests for toxins or host response is likely to result in overdiagnosis, overtreatment, and increased healthcare costs. This paper was led by Dr. Pelage, who comes from UC Davis. I've spoken with him directly about his paper, and needless to say, March of 2016, we decided at Sanford to report not just the PCR, but also to report automatically toxin, because it seemed intuitively very, very much common sense. So we came out with a new guideline in March of 2016 based upon this marinating sort of push that had been going on since the fall of 2015. And so we bought into Dr. Christopher Pelage's argument and began to move in that particular direction. So there, he and Dr. Mark Wilcox, who's from the University of Leeds in Great Britain, and who is a major leader in C. difficile diagnosis and therapy in that country, take one side of this argument, and I'm going to present the other side after we present a case. Their basic statements are that recent outcome studies show that most toxin-negative patients with C. difficile detected by NAATs or culture recover spontaneously without treatment and have a significantly lower rate of adverse events than toxin-positive patients. Furthermore, the duration of symptoms for toxin-negative patients with C. diff detected by NATs is similar to that for C. difficile negative control patients. Very powerful finding. Secondly, that the guidelines in the United Kingdom and Europe now recommend toxin testing to confirm CDI in NAT-positive patients and consideration of other causes for symptoms before diagnosis and treatment of CDI in toxin-negative patients. So in other words, they were weighting the significance of the toxin assay as a determinant upon whether or not you felt the patient had C. difficile infection as opposed to colonization. Okay, so from that we present a case study. 55-year-old man who was admitted to Sanford Medical Center on 6/12 of last year with a 2 to 3 day history of bloody diarrhea associated with increasing left-sided abdominal pain, which was sharp and crampy. His appetite was poor. He did not have vomiting, fever, or chills. He did have a history of a 10-day course of both ciprofloxacin and clindamycin several weeks prior to the onset of his current syndrome. Fast backward to Dr. Shu's comments. These were prescribed for an infraorbital infection, the details of which were unclear at the time of his admission. The patient also had a history of diverticulitis about 15 years prior, and he told the providers that his symptoms at the time were somewhat reminiscent of that episode. He lived in southern Minnesota. They have rural water, but he did not drink any well water. He drank pretty much only bottled water and had not been around anyone who had been ill with diarrhea. He's a crop farmer, no animal exposures except for an indoor and outdoor cat. He's not traveled outside the region and no travel outside the United States, and he had not participated in any large event involving food preparation. So the patient was admitted to the critical care unit, and studies included a CT scan of the abdomen, which demonstrated pericolonic inflammatory changes and distension involving the descending colon down to the sigmoid junction, most suggestive of colitis. The reading radiologist said that a distal mass could not be excluded, and that there was gaseous distension of a loop of bowel across the central upper abdomen and air fluid levels in the transverse colon. Blood cultures are obtained and were negative. A comprehensive enteric pathogen panel was positive for C. diff. As you know, that's about a 20 target panel that looks for lots of stuff. Everything else was negative except for C. diff. And then the toxin assay was reported as negative. Because of that, the hospitalists repeated the test for C. difficile because they were, remember, this guideline had been in place now for about 4 or 5 months. The second test for C. diff was detected by NAT and was negative by toxin assay, so there was 2 tests. Because of the bloody diarrhea, the patient was empirically started on Levaquin and metronidazole, more directed at whatever, if I may use that term, not so much even C. diff. It was whatever I'm concerned with that can cause bloody diarrhea in a sick patient. So the Levaquin was discontinued after an initial dose, and the patient was continued on metronidazole. However, on day 3, was switched to vancomycin. Because of the degree of abdominal distension and C. diff, we were asked to see this patient. So there's the past medical history, fairly non-contributory to his problem, other than the history of diverticulitis. Past surgical history, again, unremarkable. Medications on admission. He was on no antibiotics at the time of admission, although he had that history of Cipro and Clinda in the recent past. No allergies. Interesting, no allergies. Go back to Dr. Schu's presentation. He had never smoked. Occasional alcohol, otherwise unremarkable. No inflammatory bowel disease in the family. Review of systems, as I've stated, there was really nothing else on review. No joint swelling, no nausea and vomiting. I mentioned no fevers, chills, and he had no rash. So at physical examination, he was alert-oriented, cooperative, non-toxic, but mildly ill. He was afebrile. His abdomen demonstrated overall distension, with slightly tentative palpation on the left side of the abdomen. Otherwise, unremarkable. His laboratory studies showed an initial weight count of 23,000, with a differential of 65 neutrophils and 11% bands. White count was 18,000, then 2 days later. Liver profile was within normal limits. Serum creatinine was normal, and the rest of his labs, except for his potassium being a little low, were also unremarkable. So here's his temperature course. As you can see, he really meets the definition of afebrile status, despite being a mid-50s-year-old person. Always interesting to me how much significant disease can be present and the patient can still be afebrile. Laboratory results I've already basically mentioned. Blood cultures were negative. Stool culture was negative for enteric pathogen. Already mentioned the positive C. diffs. And the repeat study, when I became involved, I asked Joe Dakota from our virology lab, who does on special request, although it's not officially been put forward, to do a cell culture toxin assay, which is considered the gold standard in terms of toxin detection. That she informally reported back as negative because, frankly, it was a little puzzling as well, especially when I show you what was actually found. CT scan of the abdomen I've already mentioned. There's his white count. So he comes in on the 12th, 23,000, drops down to 15,600, and then bumps up again as seen. So he was seen by GI on day 3, the same day I saw him, and I asked the gastroenterologist, please, is there any way you can do a colonoscopy? The gastroenterologist was quite nervous because of the exam and was concerned about the potential for perforation. However, did agree to do a flexible sigmoidoscopy. So what he found was a diffuse pseudomembrane in the proximal sigmoid colon. There was scattered diverticulate in the mid-sigmoid colon. So the patient was seen also by surgery on that same day, and the exam revealed a moderately distended abdomen with diffuse tenderness. The day after, because of concerns of possible toxic megacolon, the patient was taken to the operating room and underwent exploratory laparotomy and a total abdominal colectomy with a small stump so that restoration of intestinal continuity could be considered in the future. So here's the sigmoidoscopy, little diverticulosis initially. Part of the sigmoid colon was not that remarkable, but then you get up into the descending colon and you see these lesions here that we classically call pseudomembranes. Remember, pseudomembranes are not a true membrane. They're made up of a conglomeration of exudate and inflammatory cells, making a layer of exudative material on the colonic wall. It's a reflection of an inflammatory response, not a true membrane. And so you see in the descending colon, and then in the additional part of the sigmoid colon. And so we felt we had a very firm diagnosis of pseudomembranous colitis in a patient who was PCR positive and toxin negative. The patient was discharged. He had a little bit of a still elevated white count at 12.9, but he was then readmitted about a month later with progressive fatigue, anorexia, and weakness. His ileostomy output was also noted, and he had decreased urine output. He went into acute renal failure for a period of time, responding to fluid resuscitation. And what was interesting is that his ileostomy output over a 3-day course was just over 3,000 mLs. And so we did a C. diff study on that and was positive in the NAD fraction, negative in the toxin fraction. So he was started on IV metronidazole and oral vancomycin. We felt that he might have this rare entity called C. difficile enteritis. We classically have always thought C. difficile to be primarily a colonic process, but in fact there are cases of what are called C. difficile enteritis. His most recent admission then to Sanford Medical Center was in December of last year when he came in with chest pain. He had increased ostomy output, and so his C. diff studies were repeated again, and at that time they were negative. So we have a case then that counters sort of what we were saying in our guideline, and in the guideline we never said use the toxin as an absolute test to determine what you should do. We said in the guideline use the toxin result to consider whether or not you would delay antibiotics and use that with other factors in your consideration. So the main debate right now in the infectious disease GI literature is between two groups. Dr. Ferric Fang from Harborview Medical Center in Seattle versus Dr. Pelage from UC Davis and Dr. Wilcox from Britain. They have written a very outstanding article which I'd refer you to looking at more in depth. It's a point-counterpoint paper debating these various issues which they had previously debated back in 2010, so this is now the new version of the point-counterpoint, and here's that article in the Journal of Clinical Microbiology. So from that study then, there are a number of questions, and I'm going to run through them as quickly as I can because there's just a few very important take-homes with regards to where we're at, and I'll show you briefly then what we've decided to do with our new guideline. So why is there so much controversy about the performance of C. diff diagnostic tests? So in the paper, and I won't tell you which side said this, you can probably figure it out. There is no reliable clinical laboratory definition for CDI that accurately distinguishes true CDI from non-CDI related symptoms in all patients. Both sides, I think, would agree upon that. So if you're looking for a test to tell you what you should do, forget it. Except to say that you need a test to tell you if C. difficile is present. And even that's not perfect. Won't go there. Most diarrhea in hospitals is not due to CDI. In fact, in virtually all clinical signs and symptoms are nonspecific and occur commonly in patients without CDI. Asymptomatic C. difficile colonization is also common in hospitals. The measured performance of these tests is highly dependent on the definition of CDI and the ratio of CDI to colonization in the particular population, as you might expect. There's anecdotal experiences with cases of severe CDI missed by toxin tests and promoted a desire for absolute certainty and sensitivity regardless of the specificity, and an erroneous belief that all patients with toxigenic C. diff and diarrhea have CDI as the cause of their symptoms. And then C. diffs, including those with the same target, vary in performance, and sometimes there's marked variance. The next question, why do studies of symptoms and clinical outcomes in patients who have C. difficile DNA or bacteria but not toxins reach such different conclusions? So gnats and culture-based methods are more sensitive, but they're less specific, as we've said. Toxin assays being the less sensitive, and so patient selection, here's one of the take-homes, is very crucial. You must clinically, we must use our noggins to decide if we're even going to test, and whether there are other factors that could explain increased bowel transit. No C. difficile diagnostic assay is completely specific. For clinical disease, production of toxin is essential, but not sufficient for disease, at least detectable toxin. And even patients with high fecal toxin levels may be asymptomatic. Again, very interesting. It's equally important to recognize that toxin assays can be negative in patients with symptomatic CDI, and the insensitivity of the toxin assays have been demonstrated even for cases of pseudomembranous colitis, and was a major consideration leading to the development of more sensitive gnats. So we had our case had pseudomembranous CDI, and in the old days we may have missed that diagnosis by using simply a toxin assay. I talked to Barb, who's a Aristi from our lead microbiology tech, and in our hands, over the last, and I think this goes back, in our hands, the percentage of patients who are positive by a PCR test, of those patients, only about 35% of them will be toxin positive. Okay? So there's a great number of patients in our experience, and I think you say, well, why isn't it higher? Why isn't it up more in that 70 to 80%? And I think it's simply because we are very likely detecting community colonization of patients who come into the hospital, who for whatever reason begin to have increased bowel transit, and we test them, and we as physicians are prone to do, we do a knee-jerk reaction. Oop, C. diff positive, patient with diarrhea, I got to treat. So a false toxin assay is a risk factor for fatal outcome in patients with fulminant CDI. Again, rather counterintuitive. The greater sensitivity of a gnat or culture-based diagnostic methods can increase the likelihood of false positive results, particularly with a low clinical probability, again, this colonization phenomenon. So, big take home, the best way to avoid false positive tests is to restrict. False positive is a misnomer almost, because a false positive test you're saying is false positive for CDI. You're not saying that the organism is not there, right? So we're talking about a PCR positive, toxin negative patient who ends up not having a CDI. We would consider that person false positive. But it's to restrict diagnostic testing to patients who have clinical presentations consistent with CDI, and inappropriate testing can indeed account for many of the reported instances of overdiagnosis. So the data is very much conflicting between these two groups. Dr. Fang feels that it's highly conflicted and therefore is very much in the camp of a PCR alone approach. using clinical input. Should be based upon clinical assessment. The safety of withholding antimicrobial treatment from symptomatic patients with positive NATs and a negative toxin assay has not been established. Untreated patients will also continue to shed C. difficile with the potential to transmit to others, in contrast to those receiving specific antimicrobial treatment. Question, what is the significance of asymptomatic carriage? So they are we believe, an important source of C. difficile transmission, and are at substantially increased personal risk for eventual development of symptomatic CDI. And Dr. Fang said that a recent study suggested that detection and isolation of colonized patients can present hospital-acquired CDI, and CDC analysis has concluded that reduced transmission due to the isolation of carriers is responsible for reduction of CDI incidence. High-risk antibiotics, some of which have already been mentioned today, should be avoided if all possible in patients with known to carry toxigenic C. difficile, and the possibility of CDI should be immediately considered if fever, diarrhea, or other compatible symptoms develop. Last question. Much of the debate seems to be about the potential for false positives. What are the consequences of administering antibiotics to treat C. difficile infection to patients who are colonized but not infected? So administering antibiotics to asymptomatic colonized patients will not provide a clinical benefit, will disrupt the host microbiota, and the use of unnecessary antibiotics can also promote the emergence of antibiotic-resistant organisms such as VRE and others. Metronidazole and vancomycin increase the risk of colonization and infection with multi-drug-resistant organisms and promote potential rebound overgrowth of C. diff in colonized patients after antibiotic discontinuation, which can potentially lead to prolonged shedding. Reflexive patients of patients with positive, treatment of patients with positive results can also lead to delayed recognition of outbreaks. So, some closing considerations. Because of the uncertainty of which testing approach is most accurate in predicting that a patient has CDI, it is clear that a pre-analytic consideration are essential in determining those who should be treated for CDI. Ensuring that tested patients have documented diarrheal disease, have not received laxatives or other bowel stimulants in the past 48 hours is really essential for diagnostic accuracy, regardless of the testing approach. It is interesting to note that the ASM has a group that is currently working on an evidence-based practice guideline for laboratory detection of C. diff, and so we hope for further clarity, and that there are 15 different reference methods that have appeared in literature today. So as a result of that, we redid our guideline, and we have gone over to Dr. Fang's side for the moment. We've moved away from Dr. Pelage and Dr. Wilcox because we want the doctors, we want our colleagues, we want ourselves to think and not just react to a result. So what we've said is we've defined CDI, we've put right next there CDI risk factors, and then we've put right up on top test considerations for patients suspected. Does the patient have clinically significant diarrhea, which we define as greater than, is at least 3 or greater than 3 watery stools per day for at least a day? If not, consider delaying testing. And so we've empowered our clinical microbiology colleagues that they can reject stools that don't meet that definition of watery diarrhea. Does the patient have alternative potential causes of diarrhea, such as laxatives, and again, could consider delaying clinically with a clinical consideration, oral contrast, tube feedings, and so forth and so on. So we then go through basically the rest of the guideline included what do you do with a PCR positive. So a decision to treat for CDI should be clinically driven, including the identification of CDI risk factors and assessment of alternative causes. A PCR positive test indicates the presence of C. difficile with the capacity to produce toxin. The PCR does not indicate whether toxin is present. So we've defined mild, moderate to severe, and severe, and we talk about some additional treatment considerations, and you can go on the Sanford intranet as you practice there to take a look at this because it is now posted. And we try to throw in some clinical pearls. We specifically say here that a specific C. difficile toxin assay may be separately ordered, but it should be noted that there's currently no consensus in the literature as to the predictive value of the toxin assay to differentiate CDI from C. difficile colonization. Patients with CDI may have no detectable toxin, and C. difficile colonization may have detectable toxin present. Couple minutes to spare. So I don't know if you have any questions for myself, Dr. Hoover, Dr. Shu? Yeah. Not as a default. No, we're not. It's something you could consider. You could order it as a separate test. We're saying use your clinical acumen. It's amazing if you just take a little time how much you can separate out. And you can clinically determine whether you think it's high probability of whether this patient has C. diff or not. So we're putting it back on the physician's, the diagnostician's shoulders to make that decision. Yeah. Yeah. So we're leaving a caveat that that there's a debate too. You know, and we're not saying that Dr. Fang is completely right. We're not saying that Dr. Pelage and Dr. Wilcox, but there's a lot of people in that other group that do believe that toxin measurement is a significant clinical tool that helps you make treatment decisions. We just don't think that there's enough agreement that we can put it into a guideline and recommend and say to a physician, oh, if the toxin is negative and the PCR is positive, you can delay treatment. Because if we can see in this case, you can have pseudomembranous colitis, and the patient can, albeit he was on metronidazole from the get-go, you know, you could see delay in treatment may have devastating potential consequences. Great question, though. Yeah, Dr. Peter Wright. They're not all. They're also not respiratory borne. So, but that's a question for Dr. Hoover. So the question is, what is the criteria of why we use community in community-acquired pneumonia?
It's a term that's come into use to indicate it was acquired not in the hospital or nursing home, not in a healthcare setting. And so if a person's in the healthcare setting, you're right, they're still not catching pneumonia from someone else, but they themselves probably have a different flora, which might include more resistant organisms than the person who is dwelling in the community or by themselves in the woods.
Yeah, the classical thing is you come down with Haemophilus influenza, you're colonized with strep pneumo, the virus opens the door, the bacteria walks in. It's a community acquired, even though those organisms were inherent to the patient themselves. Yeah, that's true. They did, and yeah. So thank you. Yeah, yeah, yeah.